students are here, and basically this lecture had been designed for undergraduates, and for undergraduates it means all over the country and especially the medical colleges in Uttar Pradesh. Fractured neck femur is a very unsolved problem till date. This is one of the fractures which is very prone not to unite, especially the intracapsular fractures. And even those which unite, in 2 years' time, the femoral head becomes avascular, what we call avascular necrosis. So, if you look at the literature, just on an average, the words which have been written in literature is an intracapsular fracture neck femur, if it is treated within 24 hours and all the conditions are met, such as a young patient, a beautiful reduction, stable fixation, even then the 50% of them do not unite. And the one which unite, out of that, 13 to 17% can become avascular. So, overall success rate in a young patient who has been treated very scientifically, energetically, at a good center, the success rate goes around 35, 40, 45% on an average. That is why when this fracture happens in elderly, active elderly, the option of replacement is the one only available. Very difficult to go for osteosynthesis, which is more likely to fail. That is why the options start that after 50s or 60s, when this fracture happens, either we should go for a heavy arthroplasty, or these days there was a talk about total hip arthroplasty. But a recent article and a study conducted in 14 countries all over the world has proved that in a neck femur fracture, especially intracapsular, there is no advantage of total hip replacement over heavy arthroplasty, a significant advantage. This study has been published on 26 September 2019 in the New England Journal of Medicine, which clearly proves that total hip replacement has no edge over heavy arthroplasty in intracapsular fracture neck femur in elderly. Hence, all the marketing forces which are driving all over the world to lure surgeons to go for total hip replacement should be looked with a dismay. Now, we are going to look at the very basics about the neck femur fracture. Neck connects head with shaft, and it is about 3.7 centimeter long. It makes angle with the shaft 130 plus minus 7 degrees. This angle is less in female due to their wider pelvis, as the nature has made them so. It facilitates movements of hip joint. It is strengthened by calcar femoral, bony thickening along its concavity. The extracapsular ring is formed. This is about the blood supply, which is very important to know. The extracapsular arterial ring is formed posteriorly by a lateral branch of the medial femoral circumflex artery, and interiorly by a branch of the lateral femoral circumflex artery. The superior and inferior gluteal arteries also have minor contributions to this ring. The ascending cervical arteries can be divided into 4 groups: anterior, medial, posterior, and lateral, based on their relationship to the femoral neck. Lateral group provides most of the blood supply to the femoral head and neck. The artery of the ligamentum teres is a branch of the obturator or the medial femoral circumflex artery. Only small and variable amount of femoral head is nourished by artery of ligamentum teres. Some new concepts in vascular supply is as follows. Lateral circumflex femoral artery only supplies neck of the femur. Most of head of femur is supplied from posterior aspect through posterior-superior and posterior-inferior branches of medial circumflex femoral artery. Hence, the medial circumflex femoral artery seems to be responsible for more likely to cause for AVN if it is occluded or if it is disrupted. Piriformis branch of inferior gluteal artery also supplies the femoral head. Minor areas near fovea supplied by artery to ligamentum teres. And this explains the pathology that happens in Perthes disease, where the artery of ligamentum teres has not yet developed, but between 4 to 8 years, because of the development and the changes in the blood supply, the head becomes more prone for having avian-like changes, what we call the Perthes disease, where there is a avascular necrosis basically of the femoral head. So here is the diagrammatic representation, the foveal artery coming from obturator artery, and there is a ring that is made on extracapsular area. From there, the arteries travel through the retinaculum, supplying the head. But as we saw in the last slide, maximum supply comes from the medial circumflex femoral artery, the head supply to the head. Lateral femoral circumflex artery mainly supplies the neck area. Now we talk about the fractures of the neck of femur. It has been divided into two main groups, the extracapsular and the intracapsular. Extracapsular ones have got a very rich blood supply and mostly they unite, commonly known as trochanteric fractures. Fixation required in displaced fractures with proximal femoral nail, PFN, these days they call it commonly in a short term, or dynamic heavy screw. And the intracapsular neck femur fracture, this is the dilemma, this is the most controversial fracture and the most prone for not uniting or goes into non-union. True femoral neck fracture, risk of avascular necrosis is very high due to its precarious and blood supply, as we talked in our previous slides. Here is the diagrammatic representation of the various areas. Femoral head, there is a pointer. The neck, greater trochanter, these are anatomical landmarks, we are all familiar. Extracapsular fractures come right up to the subtrochanteric area, that is about 5 centimeter distal to the lesser trochanter. कैसे होगा? कहाँ से? Anyway, it's very clear. The intracapsular area is the shedded area, and the fractures in these areas are the one which are prone for non-union as well as avian necrosis, avascular necrosis of the femoral head. They are prone for not uniting, and hence arthroplasty becomes the option in elderly patients. As we talked initially, that these fractures are challenged all over the world, and a good conditions if are met. A young patient comes to hospital within 24 hours, good and stable reduction, nice fixation, even then the chances of non-union are very high, approximately 50%. However, on the other hand, the extracapsular fractures are quite good. They occur in young adults due to high velocity trauma, but mostly in older people. The dictum and the usual saying is that extracapsular fractures occur in extra age, and there are extra external rotation deformity, and there is extra shortening in comparison to the intracapsular fracture neck femur. Most fractures are displaced with distal fragment, externally rotated, adducted, and proximally migrated. So there is a shortening. So the attitude of the limb is external rotation, adduction, and shortening. These displacements are less marked than in intertrochanteric fractures because the capsule of the hip joint is attached to distal fragment and prevent extreme rotation and displacement of distal fragment. Extracapsular fractures are extracapsular, so intracapsular fractures are within the capsule, so the capsule prevents too much deformity, too much shortening, too much rotation. And this is a diagrammatic representation. The foot goes in external rotation, and it is an intracapsular fracture, which is being displayed here. Adductors are pulling up, so there is a shortening, there is an external rotation, there is adduction, etc. as a deformity. Intracapsular fracture, neck femur fractures etiology. Minor trauma, slip and fall. Common site of fracture in elderly. Possible causes are weak muscle, poor balance, increased tendency to fall, postmenopausal women, osteoporosis, diabetes, stroke, and chronic debilitating diseases. Fall directly onto greater trochanter or fall from height. Let's remember the intracapsular fracture neck femur in young adults requires significant trauma to break it. But in older people who, because of imbalance, even a little strike can lead them to fall, or even a little strike can lead to fracture because of osteoporosis, and is common in females. And young patient, high energy trauma, osteomalacia, iatrogenic, pathological, and there could be conditions like giant cell tumor and other conditions that can lead to fracture of the intracapsular fracture of the neck of the femur bone. Anatomic location. Now, these fractures prognosis depends also, though it is quite understandable that the rate of union is very low, even in that group, the subcapital fractures do bad. So that is why we have divided into three types. If the fracture is just below the head, at the level of head-neck junction, that is subcapital. Another one is transcervical, and the third is basicervical, that is closer to the trochanteric area. They are relatively better to unite. Then again, it also depends upon the fracture pattern, how the fracture pattern behaves, and then we talk about the Powell's angle. How much angle, the more the vertical the fracture is, more shearing forces, less compressive forces, and more chances of non-union. That has been again divided into three grades according to Powell's classification: 30 degrees, 30 to 50, and more than 50 degrees. Angle measured from the horizontal plane and the fracture line. So this angle, the angle, Powell's angle, and the location of the fracture again decides the incidence of union. Powell, yes, we have come to the Powell. This is based on the angle of fracture from the horizontal. Type 1 is less than 30 degrees, type 2, 30 to 50 degrees, and type 3 is 50 to 70 degrees. You can see the type 3 fractures are very, very vertical. So because of muscular forces, there is a lot of shearing forces, not compressive forces. We all know that compressive forces are important for any fracture to unite, and the same rule applies here in the neck femur fractures. And here is a diagrammatic representation which you can easily remember. The angle, we don't have a pointer, I think. Oh, yes. See, you can see that this fracture line, and this fracture line. So as the fracture line becomes more and more vertical, chances of union becomes less and less. That is why this is grade 1, type 1. This is Powell's type 2, and this is Powell's type 3, which is very unlikely that we should unite. And again, it is the position of the fracture, subcapital, or transverse, or basicervical. Basicervical are the best one to unite, relatively, but again, angle and the type, these two decide the union, and the age, of course, we know. Garden classification. The Garden classification is based on not on the fracture line and its angle from the horizontal, but displacement. Stage 1, incomplete fracture of the neck, so-called abducted or impacted fractures. In our days, when we were residents, the treatment used to be just keep them in bed with boot and bar. But nowadays, any impacted fracture should always be fixed, lest it gets impacted and then goes in non-union. So Gardner's grade 1 is an incomplete fracture of the neck. Stage 2 is complete, but there is no displacement. Fracture is there, is still in situ. Grade 3, complete with partial displacement, fragments are still connected by posterior retinacular attachment, and there is malalignment of the femoral tubercle. And stage 4, this is a complete femoral neck fracture with full displacement of the proximal fragment is free and lies correctly in the sternum, so that the tubercle appears normally aligned, trabeculae appears normally aligned. Now again, this is again telling you about the prognosis and the future about union. Type 1, Gardner type 1 is better than type 2. Type 2 has got a better chance of union than type 3. And type 3 has got a better chance of union than type 4. So Powell's angle, location of the fracture, Gardner's grading, all these parameters lead to the chances of union after secure fixation. And the overall results are even then over what we have talked in our before this talk in the earlier few minutes. Mechanism of injury. Once again, low energy trauma, most common in older patients, direct. A fall onto the greater trochanter, valgus impaction, or forced external rotation of the lower extremity impinges an osteoporotic neck onto the posterior lip of the acetabulum, resulting in posterior comminution. Indirect is due to muscle forces overwhelms the strength of the femoral neck. High energy trauma accounts for femoral neck fractures in both younger and older, but obviously in the younger patient, older people can have fracture with minimal trauma as well. Patients such as motor vehicle accidents or fall from a significant height. Cyclical loading stress fractures. These are seen in athletes, military recruits. We all know that military recruits have got a fracture in the shin area, what we call a stress fracture, treated by vitamin D. Similarly, stress fracture can occur in athletes, ballet dancers, patients with osteoporosis and osteopenia are at particular risk. Osteomalacia in young people, there is a fracture as well. That is also comes under stress fractures. So clinical presentations are fall from height, non-ambulatory on presentation, except impacted fracture patients may still be able to walk. Impacted fracture neck femur fracture patients are able to walk, but they will complain of pain in the groin. And when you take an X-ray, at times there could be a doubt. So in this situation, an MR scan is always helpful. But we should not try to do an external rotation or any kind of clinical test, lest it can be disimpacted. Once we diagnose it, these days, the modern days treatment is to fix them in situ with cannulated cancellous screws. You can look at the attitude of the limb. You can also see that there is a shortening, there is external rotation. So external rotation and shortening after the tibial trauma in an active elderly clearly says that there is a fracture. Now, to tell it is intracapsular or extracapsular, which bears a very important role on the prognosis. If it is an extracapsular, the chances of union are much better. And if it is intracapsular, obviously, in an active elderly patient above 60, the chances of union become very bleak, and then the option comes about replacing the broken neck or replacing the head, what we call a hemiarthroplasty. Pain is evident on range of hip motion with possible pain on axial compression and tenderness to palpation of the groin. Tenderness over Scarpa's triangle, active SLR is not possible. This is very important. If you ask the patient to raise the limb, someone with a fracture neck femur cannot do it. You call it active straight leg rising test. Diagnosis is then simple and easy. Situations in which femoral leg fracture may be missed. Stress fractures can be missed. Elderly patient with unexplained pain in the hip should be considered to have a stress fracture until proven otherwise. Undisplaced fractures, impacted fractures may be difficult to visualize on plain X-ray, as I told you earlier. Painless fractures, a bedridden patient may develop a silent fracture that can happen in diabetics. Multiple fracture patients with a femoral shaft fracture may also have a hip fracture which is easily missed unless the pelvis is X-rayed. Radiographic evaluation, an anteroposterior view of the pelvis, both hips in 15 degrees of internal rotation, a cross-table lateral view of the involved proximal femur are indicated. Why 15 degree internal rotation? Because we know that femur has got 15 degree inversion. When we internally rotate, the whole length of the neck is visualized. That is why we do it X-ray in 15 degrees of internal rotation. That is important at the undergraduate level to understand that. Technetium bone scan or preferably magnetic resonance imaging may be of critical utility in delineating non-displaced or occult fractures that are not apparent on plain radiographs. What is sentence line? Sentence line is a line formed by the inferior aspect of the superior pubic ramus and the medial aspect of the upper femur. Sentence line should describe a smooth curve. If there is any sharp angulation of sentence line, the patient could have a neck of femur fracture. An abnormal sentence line can be the most obvious indicator of a patient's femoral neck of femur demonstrated on an AP pelvis hip image. Here is the line. So from here, that line is a continuous. If there is any break in this line, that again says about that there is a cortical breach and there could be a fracture. This is a radiograph showing you this is the normal side and here is the fracture. What type of fracture it is? Obviously, it is at the neck and the head junction. So that is a subcapital fracture, right? And then you have to look for again, if you want to know, the Powell's grading can be a horizontal line from there to there, and line drawn through the fracture this way, and that angle makes the Powell's angle. And then again, you can also look for the Gardens. It is Gardens type 4 because the head is totally free, and the type 3 or type 4. Obviously, this is not an impacted. Obviously, this is not Garden type 1 or 2. It goes in 3. So Powell's angle, Garden type, and the location of the fracture, and the age, and the time. All these factors decide regarding union. Complications. Avascular necrosis. Incidence is around 10 to 45%. This is a very wide range. Recent studies fail to demonstrate association between time to fracture reduction and subsequent AVN. However, the literature says that you should try to reduce as early as possible if we are imagining about union. So in a young patient, the time is important. Within 24 hours, if you reduce the fracture, fix it, stabilize it nicely, the chances may be better of not developing the avascular necrosis. It is taken as an emergency in the Western countries. It is worth mentioning here, in our country, we are not aware about the seriousness of this fracture. Many times from the villages, they are referred. It goes for days, weeks, and at times months before they reach the hospital or they see the surgeon. That is why after 3 weeks, we usually do not aim, or we don't think, and we have a very pessimistic outlook regarding union. in this notorious fracture. Increased risk with increased initial displacement, AVN, can still develop in non-displaced injuries, non-anatomical reduction. Treatment. Young patients, more than 50% involvement, then treat. Young patients, more than 50% involvement, then treat total hip arthroplasty. Other older patients, prosthetic replacement, hemiarthroplasty versus total hip arthroplasty. I do not want to confuse the audience here that the treatment of an intracapsular neck femur fracture could be total hip arthroplasty, especially in this country. Even in developed country, as I told you earlier, a recent paper, 26 September, published in New England Journal, and multi-centric study in 14 countries has clearly proved that total hip arthroplasty is not the right choice, cannot edge over hemiarthroplasty significantly in active elderly patients. And this statement goes so well with a developing country like ours, where every hospital doesn't have the facility, and moreover the surgeons are not that well trained, and then our patients want to sit and squat. After total hip arthroplasty, we all know that companies don't allow sitting and squatting, which is our cultural need, but that can be done with the hemiarthroplastic-like scenario. Hence, talking about hemiarthroplasty is really not needed or should not be talked at all as a treatment option for intracapsular fracture neck femur. And other way, we want to preserve with the nature where the cartilage is nice. Why should we disrupt the cartilage? Non-union incidence of 5 to 30% increased incidence in displaced fractures. No correlation between age, gender, and rate of non-union. Varus malreduction most closely correlates with failure of fixation after reduction and convoluted screw fixation. So treatment, valgus intertrochanteric osteotomy, free vascularized tubular graft, which is a very technically demanding surgery, not possible in most of the setups. Revision, open reduction and internal fixation, and malunion, less common. Fracture does not unite mostly, so the chances of malunion is very unlikely. Malunion can be with extracapsular fracture neck femurs, but not with the intracapsulars. Treatment, goals of treatment are to minimize patient discomfort, restore hip function, allow rapid mobilization by obtaining early anatomic reduction and stable internal fixation or prosthetic replacement. In children, close reduction and hip spica could be good enough. If not reduced, then open reduction and internal fixation with Moore spins. Adults impacted or Gardner type 1 and 2, we have mentioned about Gardner types. Non-operative treatment, bed rest for elderly person whose medical condition carries an excessive high risk of mortality from anesthesia and surgery. If that is not there, no medical controversy is there, medically they can be given, they can be anesthetized, then best option would be to fix in situ with convoluted cancellous screw, even in impacted fractures. Operative treatment include the following: internal fixation with multiple cancellous screws, preferred treatment, sliding hip screws, DHS, DCS. Advantages: biomechanical strength greater than multiple cancellous screws. The advantage of DHS, the biomechanical strength is greater than. Still, there is a study going on whether cancellous screws are better or cancellous screw with DHS. That is better. Minimization of risk of subsequent subtrochanteric fracture, secondary to stress riser effect. Placement of compression across the fracture at the time of reduction. Stabilization include a larger surgical exposure, potential to create rotational malalignment of the femoral head. This is in a comparison between convoluted cancellous screws and DHS with convoluted cancellous screws. So here is example, you can see that was a type 4 fracture, this one, and if I point here, it will not go there, it's not right. And this is a 3 screw fixation, and the lateral view and the AP view. This is the example of cannulated cancellous screw fixation, Garden type 4. And the top slide, this is an example of Garden type 2. Both the cortices are gone, but we can treat it as an impacted one fixed with a cannulated cancellous screw. And in the lower slides, you can see that even after reduction, the union has happened, but it has gone into avascular necrosis. So even if the fracture unites, the surgeon has to watch at least for 2 years to see if the head is not going into avascular necrosis. And that is why these days, after fixation and union, we try to give some studies that have shown that alendronate probably helps in preventing the avascular necrosis. So alendronate should be added apart from the surgical treatment to prevent avascular necrosis. And finally, the treatment is that if it goes into AVN, then we can come and we can treat it with a total hip replacement surgery, which is being shown here. However, if the person is around 60 or 60 plus, you do not have to necessarily go for a total hip. You can treat it with a hemiarthroplasty as well, because osteoarthritic changes are not there in the sternum. If there is not osteoarthritic change in the sternum, it can be treated with hemiarthroplasty, especially good for this country because it provides you sitting and squatting, quicker surgery, less blood loss, and of course the economic constraints and technical expertise. Displaced or Garden type 3 and 4 fractures. Age is less than 60 years. Internal fixation should be done, and an attempt should be made to make the fracture unite. Multiple cancellous screws most commonly used. Dynamic hip screw can be used. Smith-Peterson nail is not used these days and outdated. You can add up another a cannulated cancellous screw at the top to prevent the rotation. So a DHS with a cancellous screw can also be a better option. Displaced femoral leg fractures in elderly. Elderly, non-ambulator, unipolar hip prosthesis, Austin Moore or Thompson. Here the word is being used non-ambulatory. That means before the fracture happened, patient was not mobile much. In those situations, we can just give them a life little better and painless. A unipolar hip prosthesis, Austin Moore or Thompson type can be used. Elderly active ambulators, physiologically younger, lot of debate over treatment of choice nowadays. A, bipolar hemi replacement. Less than 5 years survival. We cannot know about how much somebody is going to survive, but if the person is going to survive not more than 2 years, one can go for Austin Moore. The indications for Austin Moore, which has come in the literature very clearly, is that someone who was a non-ambulator or a house-bound ambulator, life expectancy less than 2 years, and the age above 80, you can treat it with a unipolar prosthesis or Austin Moore type of prosthesis. But a villager actively working and going to the fields above 60, if he breaks his neck femur, intracapsular fracture neck femur, probably a bipolar prosthesis should be the choice in our country or anywhere in the world. Developing countries due to limited health resources. Talwarkar, oh, you have added this one. Talwarkar, BHU bipolar and modular. Now, here is a word to all the undergraduates, postgraduates and the surgeons. Modular. You should no need of modularity if it is a fresh intracapsular fracture neck femur, and if you cut the femur about a little finger breadth above the lesser trochanter, in that situation, you do not need any modularity to maintain the limb length. A simple bipolar prosthesis will give you, a BHU bipolar prosthesis is going to give you equal limb length. Even after total hip replacement, advocates of total hip replacement to say, but even after that, limb length discrepancy could be. A 1 centimeter limb length discrepancy doesn't lead to any clinical problem to the patient. Body conceals this and adaptive mechanisms of the muscles, they make the gait almost normal line. So, we should choose a prosthesis which has got advantages. Talwalkar type, nothing to carry, it is an ages long being used in this country, but reports have come, the Talwalkar hemiorthoplasty bipolar fails within 5 years, and it is always revised within 5 years. And the inner bearing movements of this bipolar prosthesis dies out in about 2 to 3 to 4 months' time. The studies have proved, as several papers have been published. The BHU bipolar prosthesis developed in this institution has proved over 12 years of period preservation of the movement at the inner bearing and hardly any limb length discrepancy if it is done properly, keeping a little finger breadth above the lesser trochanter if you can save that bone. And no need of modularity. So most of the spine surgeons, when they use bipolar, they talk about modularity, that you have to have a module. No need of modularity in a neck femur fracture if you have got the neck preserved, a little finger breadth above the lesser trochanter neck is there. No need to use a bipolar prosthesis, a modular prosthesis to maintain the limb length. Limb length becomes almost equal. Now, B, total hip replacement. Treatment of choice in longer expected cervical, more than 5 years, but associated with more dislocations than hemiorthoplasty. As we have already talked, in the next, we have already talked that the recent publication of 2019 a randomized trial, prospective trial in 14 countries and paper published in New England Journal has clearly shown that total hip orthoplasty has no significant advantage over hemiorthoplasty. That is Mohit Bhandari's paper, and that can be looked about. So no question about talking about total hip orthoplasty as a treatment option for intracapsular fracture neck femur in active elderly. This is an example of osteomer prosthesis developed in around South America and in 80s, and long prevailed all over the world. And this is Thompson prosthesis. You can see that the collar is so low. So when you put this prosthesis, when there is no bone above the lesser trochanter, and this is used with cement, here these holes are there. They say that these holes are there so that the bone can grow. This is used when there is a bone above the lesser trochanter is still available. But if that bone is not available, you have to go for Thompson. But again, at this junction, I would be mentioning the indications for these unipolar processes is 80 years, housebound ambulator, and age expectancy less than 2 years. Otherwise, they're not used. Still in this situation, you can use a bipolar prosthesis. Doesn't make you not to use it. Indications for hemiorthoplasty. Comminuted displaced femoral neck fractures in the elderly, pathological fractures, poor medical condition, poor ambulatory status before fracture, neurological conditions, dementia, ataxia, hemiplegia, and Parkinsonism. Advantages of BHU bipolar hemiorthoplasty over other bipolars. I don't know whether the audience is still there listening or they're bored. Maintains bipolar property for long period, allows patients to cross legs sitting and squatting, which is our primary cultural need in this country. Very less dislocation rates because of the design that we will talk, which is because of the ellipsoidal design of the bipolar. Disadvantage of bipolar over THR, a risk of vestibular erosion exists in active individuals. So inactive patients, younger patients. Here is the example of this bipolar prosthesis. You can look at the head. Head is not a half circle. So if it is not a half circle like other bipolars, it does not sink into the sternum or doesn't remain at the level of the sternal margin, but it hangs out. Hence, in the extremes of movement, the dislocation is less likely. And the second point, if you look at the plastic material the polyethylene is in a staggering fashion and sloping way, so the neck does not hit the poly. The hitting of the neck with the poly has been proved as a very important cause of the polyethylene debris studding and stagnation of the movement at the inner bearing. Now look at the neck. Neck has got a trapezoidal shape, sort of, so that the neck does not hit the poly and the range of the movement becomes more clinically. So advantage is clinical range of movement becomes more. There is no hitting of the poly with the neck. Ellipsoidal cup prevents the dislocation, and angle of the calcar is like Austin Moore, less than that. Austin Moore, you preserve about 1.5 centimeter of the femoral neck should be there. Here, if there is a little finger press, about quarter centimeter, if this much neck here can be preserved, you can use the bipolar. Then my hands are trembling. This at this area, about a quarter centimeter. And the last thing, the head inside, this is important. The head inside has got a Charnley head diameter, that is 22.24, 22 millimeter. What is the advantage of having a small head? Because for the same outer diameter, if you use the BHU bipolar processes, you have got 8 years extra survival because of the thickness of the poly. If the Thalwalkar type of bipolar has got 28 millimeter inner head, so the poly becomes much thinner. And the infinite element analysis says that the wear in a bipolar is very fast if the inner plastic material goes below 5 millimeter. So hence a 22 millimeter diameter head gives you 7 to 8 years more life, gives you positive eccentricity, and neck cup impingement avoidance makes the inner movement preserving for a longer time. Less collar angle preserves the calcar bones as a hard bone to sit if you are using these processes without cement. And the trapezoidal neck, which is not shown in this design, but the neck has got its color like a hanging rope, and that gives you a wider range of clinical movement. And our studies have shown that the offset is almost like normal. There is no significant difference in offset once this process is used between the norm from the normal side. This is a variety of uncemented. Once you put the processes, and if you draw a line from the top of the GT and draw it, it goes to the center, and that should be the ideal situation. And obviously, there is no limb length discrepancy if you measure it from the ischial tuberosity. And obviously, when it is going from the top of the GT, is going from the center, obviously there is not much difference. Bipolar hemiarthroplastic in trochanteric fractures, you can use that at times, like this patient, which had been planned for a total hip replacement. But the patient's age was very high. She was in 75, and we wanted her to allow walking. We also wanted that she should not dislocate because of the poor musculature. So we decided to use it, and this has been used with cement, and she is mobilizing. So this is a BHU device. Firstly, we had planned to treat it with a total hip. Patient had been consent, but undergoing the acetabulum, we found the cartilage is fine. And she has to survive 10, 15 years maximum. That processes can really stay till that time. And with the added advantage, fearlessly, without any fear, you can allow the patient to sit and cross-legged sitting, it can be allowed, which is the prime need of our patients coming from villages. Modular bipolar, this is an example. Here we are using a modular bipolar. This is the processes, imported one, costing quite high, something in 50s. So what is the advantage of this modular bipolar? If there is a neck, you can maintain the limb length. You can maintain the limb length by a simple 5,000 rupees processes or 10,000 rupees processes. So no need of modularity. We use modularity where? Modularity you need to maintain the limb length. As I told you, if there is a bone available about a quarter centimeter above the lesser trochanter, you don't need modularity, which is the common situation 90% times. Fracture neck femur with pre-existing degenerative condition, total hip replacement indications. Yes, of course, these are osteoarthritis, rheumatoid arthritis, severe osteoporosis, pathological conditions with acetabular involvement such as Paget's disease. Here is an example of a total hip replacement where we have replaced where we have reamed it and put a cementless cup which is coated with hydroxyapatite or plasma coated, and there's a stent with that one. Changing both the sides is total hip. Any questions? सर श्रोता कौन कौन लोग हैं पता नहीं हैं? तो क्या करोगे, इसको डिस्प्ले करोगे बाद में? Thank you very much. Anybody have got any question now? Please ask any questions if you want to. Huh? I show you an example. This is a very heavy lady. Avascular necrosis of bilateral hip joint with secondary osteoarthritis, right hip joint for which BHU bipolar hip and hemiarthroplasty done bilateral side now, presenting with osteolysis and pain. So you can see that I do not want to say that the bipolar orthoplasty is the right choice, but it can work because of the economic constraints. One side, both sides was done the BHU hip device. It has been not done properly, done by residents at that time. So we had to rechange it, and we did. Now both the sides you are seeing, one side is the BHU bipolar, other side is total hip. This is down the line 6 years, second surgery. Patient is happy, but she has obviously no pain. 6 years has passed, if at all. This is no. This is the first time treated by BHU bipolar processes, but there was pain, and then we had to revise it, and we took out the bipolar from one side and we changed into the total hip. Now this is the 6 years down the line. Patient has got some pain on the side on which side the THR has been done, but she has no pain on the side the BHU bipolar process has been done. Why the other side failed, I have no comments. Probably that side had been done by beginners, by the residents. So some pain came up. We had to revise it with total hip. अरे वो मोहित भंडारी का पेपर लगा. क्वेश्चंस भाई फमरेश जी, आप लोगों को अगर कहीं कुछ बात क्वेश्चन उठ रहा हो मन में तो बताइए. विदाउट एनी फियर प्लीज आस्क.
फ्रैक्चर लाइन लेते हैं जो सर पाउल्स एंगल में, वो हेड के फ्रैक्चर से लेते हैं कि नेक वाले फ्रैक्चर लाइन से लेते हैं?
Well, the fracture is between the head and the neck area. The transverse line on the X-ray plate and the fracture line. You just draw wherever you can see in the X-ray the fracture line and extend it. That angle, simple.
और लिम्ब रोटेशन से कोई डिफरेंस होता है सर कि एंगल अलग?
Well, possibly you should try to be in neutral. Then only you can be better aligned. The limb should be in neutral. The X-ray, yes. Yes, Dr. Arsad.
Have chance of avian in first 6 hours of the trauma. Fracture neck of femur.
You want to say that if you operate within 6 hours?
Yes, sir. What is the chance of avian?
Avian.
Yes, sir.
No, that as I saw in the last slide, they were saying that not much difference. The avian, what we have observed peculiarly, and Professor Goel was also of the view, those fractures which do not unite and you don't fix them, there the head never becomes avian. Even after 3 years, after 2 years, and ununited, where no attempt has been made to make them unite, no surgery has been done. In those situations, head has not become avascular. But those who have been fixed, they are the one who show avascularity or avian changes. Regarding time, of course, as far as early you can fix it, fine. But there is no paper or there is no study that can say you that if you fix it within 6 hours or if you can fix it after 48 hours, that would make a difference. But obviously, time has got a role. Nowadays, they say that when you are fixing, you should also make a small hole in the cartilage because it is a joint tamponade. When there is a fracture, there is a bleeding inside the joint and your vessels are running into the retinaculum and the pressure from outside, that occludes them. So once you make a drill, the blood can go out. Something like that, they say. So that time period is not that essential, but of course you should try to fix it as early as possible.
Sir, what is the role of primary valgus osteotomy in young neck femur fractures when the Powell's angle is more than 50 degree?
Well, now that's a good question. Young guy, you can do it if the Powell's angle is between grade 3. The angle is very, very vertical. A lot of shearing forces are working. The valgus displacement, valgus osteotomy is the one that converts those shearing forces into compressive forces. Basically, by doing that osteotomy and using an angled plate, you are converting the grade. The grade 3 will become grade 2, or grade 2 will become grade 1. So you are adding up more and more compressive forces, and compressive forces are good to make to bone unite, as the Wolff's law says. Compression in the bony ends leads to union. Again, why it leads to union? You have to go in more physiological details. They say that there is a compression leads to piezoelectric phenomena and development of negative charges at that site, and the more and more calcium ions deposition. So, as your question, valgus osteotomy is basically to convert the grade of Powell's from 70 degree to 50 degree or maybe less than that, the more angle you can make. So, normally what we are using here is that double angle plate that gives you about 25 to 30 degrees maximum, 25 degrees angulation. So you can always reduce the angle. If it is 70, you can bring it to grade 2. Grade 2, you can bring it to grade 3. Okay? Thank you very much.